Hello, and welcome to the PedsNet Data Analyst Training Program and to our conversation today about electronic health records. It's great to have the opportunity to talk to all of you. I'm Charles Bailey. I am a clinical informatician and a pediatric oncologist, and I have the privilege of leading the PedsNet Data Coordinating Center. So let's start today with some background on electronic health records, which we're talking about because it's the principal source of information that goes into PedsNet. Right? So what perhaps you might say is in fact the electronic health record. We're all used to some of these components at the top in our experience in delivering care or in operating hospitals, right? So the HR is the electronics or the information systems that are present at the point of care in clinics and that interact directly with the patient. But one of the important things to remember is that as this diagram from Epic Systems, which is one of the more common software vendors in the EHR space, shows, is that electronic health record software systems actually reach into a variety of aspects of hospital operations, including not only the direct delivery of care, but maintenance of business processes, capacity planning, delivery of services such as laboratory testing or radiographic imaging, and then care of patients who are actually not present in the hospital through things such as population health or patient-reported information, mobile health, or telehealth encounters. Right? So there are a variety of ways that electronic health records can collect data and can interact with patients. And part of what we try to do in PedsNet is be aware of that and make the best use of all of the information that comes to us. So part of what we need to do as we're thinking about how we can use the electronic health record is understand some about how it came to be used in healthcare delivery and where it is and isn't present. Right, so if you look back, the earliest of the professional societies dealing with information management in electronic systems in healthcare is HIMSS, founded in 1961. So this has been with us for about 60 years. But for much of that time, health information systems and health information management focused on business processes that were a bit removed from the point of care. So things like billing and revenue cycle, or managing of supply chains, or tracking of discrete data in specialties like clinical pathology and laboratory medicine. All of that has changed, however, in the last 15 to 20 years. Right? So one of the landmarks toward the turn of the century in the excuse me, the way we interact with electronic healthcare data is the Health Insurance Portability and Accountability Act of 1996, or HIPAA, as folks talk about it routinely. So HIPAA dealt largely in the electronic health record space with the ability to exchange information describing patient care and describing the business processes around patient care. One of the provisions of the act was that the construction of rules for electronic data interchange. And following the adoption of electronic healthcare data, it took until about 2004 for the final rules to be posted. But since that time, HIPAA has had an outsized impact on the way we think about exchange of electronic healthcare data. However, it didn't by itself change the way we used electronic healthcare records in healthcare delivery, right? And in particular, what we notice is in healthcare delivery, there are significant logistical barriers to adoption of information technology, some of which have to do with the complexity of patient care, and many of which have to do with our social expectations around privacy for healthcare data. But it also has a lot to do with the culture of healthcare, with our sort of narrative approach to the way that we care for patients. Right? Finally, as you no doubt are aware, hospitals use lots of different information systems in different parts of their organization. And there was a fairly high barrier to drawing those fragmented systems together into a unified whole. Different institutions took different approaches to that. Some tended to focus on data collection into post-care warehouses. Some focused on trying to build interoperable stacks of care delivery applications, but there was really little in the way of standards for interoperability. Much of that changed a little over a decade ago with the American Recovery and Reinvestment Act that was passed after the the recession in 2008. So one component of the ARRA was the Health Information Technology for Economic and Clinical Health Act, or HITECH. In addition to amending some of the electronic data exchange provisions of HIPAA, part of what HITECH did was create a number of incentives for healthcare organizations to acquire and to deploy electronic health records and to participate in the exchange of electronic clinical data. And what you can see is that through those incentives, often referred to as the Meaningful Use Program, it was able to drive rapid adoption of electronic health records. So, in 2009, 2010, you can see that there was around 10 to 20% usage of electronic healthcare records across the healthcare enterprise. And really by 6 or 7 years later, that number had crossed 80%. Right? So it's now common practice for all of us to use electronic healthcare records when clinicians interact with patients, when hospital systems deliver care, when we record care, when we interact with outside organizations like pharmacies or freestanding laboratories. And that has really revolutionized the way that we look at electronic healthcare data as well. Among the things that has changed is that it has really expanded the scope of what we call secondary use of healthcare data. So this is the use of data that were generated in the process of delivering healthcare to a patient or in the process of running the healthcare enterprise in order to learn more about health and the care of patients. When we're doing secondary use research, given the high adoption of EHRs now, there are a number of things that we can rely on. Right? We can expect certain core data types to be present, right? Based on the design of electronic health record systems and based on the kinds of utilization that the Meaningful Use Program drove, we can expect things like scheduling data or prescribing data or laboratory data or diagnosis data to be present and available to operate on. Having said that, we have to remember that the actual clinical workflows and the ways that the EHR is integrated into those workflows do strongly influence the completeness of data. We make choices about what we do and don't record, and there are places where systems do and don't interact with each other. So that, for instance, in recording drugs, a healthcare delivery system like a hospital or a clinic is likely to have very good capture of prescribing activity because computerized prescriber order entry, or CPOE, is a core function of electronic health records. On the other hand, it may or may not have information about what patients actually receive from pharmacies or dispensing data. Prescribing data will be at the level of prescriptions written. These can span days, weeks, months in some cases, and a single record will cover all of that time. On the other hand, for inpatient medications, we often have dose-by-dose records. And so we get much more of a level of detail about dose delivered. A second thing that we need to remember is that the look-back period depends on when institutions adopted EHRs. So you'll remember from the previous slide that across the enterprise, adoption went from under 20% to over 80% in about 5 years. Right? And so you can expect with reasonable reliability that if you are studying patients in the last couple of years or since about 2017, there will be fairly wide deployment of the EHR, and you are likely to find data collected in a variety of care contexts. On the other hand, giving this talk in 2022, if you look back a decade, you will find that while many institutions had EHRs deployed, there were more places in the organization, whether it was settings with different workflows, such as operating rooms or medical device utilization, or whether it was settings that were not tightly integrated with large facilities, such as outlying clinics, where the EHR deployment was incomplete and data may therefore be incomplete. Right? And then finally, as we talked about a little while ago, the availability of external data varies. So the ability of the electronic health record to incorporate data from outside sources, such as dispensing or vaccine information systems, varies both with time as deployment increased and with place as different organizations adopted those components of the EHR. That said, there are a number of technical characteristics that are common across EHR deployments, largely due to standards that are established by the Office of the National Coordinator for Health Information Technology, often abbreviated ONC. ONC has published a set of vendor standards. These define what is called certified EHR technology, or CERT for short, and they go to what functions an EHR should provide, what parts of healthcare delivery it needs to interact with, and what structures it has to have in place in order to both store the information and exchange information with outside systems. Right? We talked a little bit about the deployment standards, the so-called Meaningful Use Initiative, which provided financial incentives to healthcare organizations to deploy electronic healthcare records. ONC has also deployed standards for data representation. So there's the core data for interoperability set of standards that looks at the way data are represented, what characteristics of the data need to be present in order to have a US CDI compliant electronic health record. And then finally, there are standards governing information exchange. So these are collectively referred to as the Interoperability Standards Advisory, and they prescribe practices for sharing information across electronic health record and other clinical information systems. These go a long way towards improving interoperability and towards setting expectations for the kind of data that will be available to you as you do secondary use research in PedsNet. So that leads to the very practical question, what happens in an EHR? It's important to remember that EHRs are fundamentally operational systems. They are fundamentally about the process of healthcare delivery. So what that means is that they are, relatively speaking, better at collecting data that changes business processes, that's involved in delivery of a service, that's involved in the revenue cycle, that's involved in use of supplies. They are better at collecting data that is needed to make utilization decisions. So if we're choosing to admit a patient or not to admit a patient, or when and whether to perform surgery, those data are collected more completely because we need to represent them in order to change the business process. And finally, EHRs are, relatively speaking, better about collecting data whose delivery, or whose collection really, has regulatory implications. On the other hand, there are spheres in which EHRs are less representative, right? So relatively speaking, EHRs tend not to be so good at capturing data about the functional or occupational impact of injuries, of illnesses, of healthcare delivery, because those things tend to happen outside the healthcare institution and don't discretely affect delivery. It can be hard to capture complex conditions or complex medical decisions because the pieces may be fragmented into different places in the EHR. And unless there is a recognized service or diagnosis code that collects those various components, it may take some work to assemble the pieces. And finally, because EHRs are often centered in healthcare delivery systems, they're lagging a bit in their ability to capture patient-entered data and to standardize that patient-entered data into a format that makes it available for secondary use. The corollary of what is, where do you find EHRs? Well, as we've talked about, you find them in health systems, right? So they're deployed in hospitals, they're deployed in clinics, they're deployed in outpatient service departments. You'll find that increasingly they're deployed in mobile health systems. Often those are channels for providing information to patients with a narrower pipe back to the EHR. But it is possible to collect data both through patient entry and through passive data capture, such things as wearable fitness devices, and feed those data back into the EHR. And then finally, we want to think about EHRs as available through patient portals. So these are often web applications that allow patients to interact with the EHR when they're outside the healthcare institution, or that support exchange of health information between institutions or between patients as they carry their data from place to place. There are conversely a number of places where the EHR is not well represented currently. As you might expect from our prior summary, they tend not to be present in day-to-day life for a lot of patients. They're the reach into the home, the reach into occupational settings, whether work or school, the reach into sort of everyday community interactions is much more limited, right? Similarly, even in places where you might see an EHR, there's uneven availability and uneven adoption because of a number of disparities, right? Some may be economic, that may affect a patient's ability to interact or even own the technology that's necessary to connect to the EHR. Educational and cultural disparities, which condition the way people interact with healthcare organizations and health information technologies, and even geographic disparities. For instance, we'll note that most PedsNet institutions are located largely in urban and suburban settings. In some cases, the reach into rural settings of information technology and of some of the less common components of electronic healthcare records is limited. All right, so we've talked mostly about EHRs as software systems and the data that reside in EHRs. I do want to mention that when you're thinking about secondary use research, it's also important to consider the availability of external data. So most EHRs will interact with some external systems directly. For instance, interaction with vaccine information systems or vaccine registries was a core part of the Meaningful Use Initiative, and nearly every EHR will interact in some fashion with local vaccine registries, although the completeness of those registries varies greatly from place to place. In some cases, the EHRs are deployed with pathways for data to feed back in from external services, such as pharmacy benefits managers providing dispensing data back to the institution for use in clinical care. Even when that doesn't happen passively, it may be possible to actively link data that is derived from the EHR to external data sources, such as payer adjudicated claims or state level or national public health data sets. And then finally, I also want to mention that there is increased adoption of messaging standards such as FHIR as a way to exchange data in smaller increments that are often useful for things like collecting longitudinal data on patients who have enrolled in clinical trials, even where they're not yet operating at the scale necessary to support large observational studies. All right, so having considered what the software systems look like, I want to talk a little bit about the kinds of data that you see in EHRs and how you might use them. And in thinking about this, I want to start with a conceptual division of data into two axes. On the x-axis here, I have what I have called definition. So this is the ability to understand what a particular piece of data in the EHR means, right? And ideally, we will agree on the meaning of things and be sort of further out toward the standard end of this axis, such as, for instance, when we talk about a concept like a patient's weight, right? You know, we would certainly need to know what the unit was, but we all have a common accepted definition of weight that tends to be determined in reasonably compatible ways. And so it's relatively interoperable, as opposed to, for instance, individual descriptions of a patient's subjective state of mind, right? Which may vary significantly from individual to individual or day to day. The second axis is what I call discreteness. It's our ability to, from a particular piece of data in the EHR, understand what was going on in a particular way at a particular point in time. Again, to choose an example, you know, the measured weight that I was talking about is something that is typically recorded with metadata about the setting and the date and the time, and produces a very clear value, right? There's a number and a unit. On the other hand, there are aspects of patients' health that we don't capture very well in discrete data, and that may only appear in narrative summaries of interactions with the healthcare system, such as clinical notes. So when doing research, ideally, we want to be up in this upper right-hand quadrant where We have data available. Those data are discrete, so we can tell one time or one type of fact from another. And the understanding of what those data means are common across settings, so that if the data are from one institution or another institution, we may have some formatting questions to address, but we're pretty clear on the content of what we're dealing with. We don't want to be down here, if we can avoid it, in the lower left corner, where information might be available, but it's hard to tell what it means. And the same representation may actually mean different things when recorded by different people. In practice, we tend to spend a lot of time in the secondary use world sort of generally on the right half of this, this notional separation, where there are reasonably well-defined meanings for the data, or at least meanings may be variable, but we know how to exchange from one to the other, and where there are reasonably separated pieces of information so that we have a general understanding, or can get to a general understanding, of when and how this information was used. We do try as much as we can to stay away from things like free text, because it's much more difficult to scale that. It's not at all impossible. Feature extraction and natural language processing is a very live art, but the complexity of the problem is different from, say, trying to make sure that all of the weights we have from multiple hospitals are in the same units. In addition to thinking about how the data are conceived, we want to think about what kinds of data we're likely to find in a network like PedsNet. So here's a brief summary of the kind of information that we collect in PedsNet core data now. In the orange, you can see that the data that we have is centered really on two components, right? Who the patient is and how they interact with the healthcare system. So that's represented in the data as demographic data about the patient, and then encounter data that marks the boundaries of interactions. Those interactions then produce a variety of information, including both primary data, things like physical measurements, laboratory values, medications used, and sort of integration by clinicians into things like diagnoses or visit types or referrals. Right? Finally, I will note that PedsNet does include some person-reported data, mostly in the form of surveys, which may be presented either directly as part of a research study or through the EHR. And through location information is also able to connect to a number of environmental measures or area level measures that describe the physical environment, the built environment that a patient lives in or gets healthcare in, and by proxy, a number of social determinants of health that can be mapped to the area in which a patient lives. Right? So how are data represented? I talked, for instance, about primary data or measures and integrated data. Really fundamentally, we are trying to represent physiologic processes that go on in patients, right? And patients never come to you with a label, right? But here, for instance, is a prototypical physiologic process, right? This is not a thing that you see in an electronic health record. This is not something that you even see when you interact with the patient, right? But what you see are the clinical manifestations of the way that this protein functions. And we can measure this protein, and then we can summarize the function of this protein in a number of different ways, right? So this is clotting factor 8, right? And deficiency or dysfunction in this protein is manifested as the clinical syndrome of hemophilia A, but that goes by a variety of names, right? Most patients will describe their condition as hemophilia, mild, moderate. Many clinicians will. Formally, in most diagnostic terminologies, it's actually known as hereditary factor 8 deficiency to distinguish it from hemophilia B, factor 9 deficiency. Often for convenience, because there are a number of ways to spell those words, or there are a number of variations on the ordering, we'll represent things as numeric or alphanumeric codes. So what you see here, for instance, is 286.0 is the ICD-9 CM diagnosis code. D66 is the ICD-10 CM diagnosis code. And the ever easy to remember 282930008 is the SNOMED code that all represents this entity. Again, none of these are things that the patient is going to tell you. They won't walk in and say, hi, I'm here for my 282930008. Right? So part of what we need to do is be careful about how we are representing data in the electronic health record and how accurately that represents the actual state of health of the patient. It turns out, for instance, that there are a variety of different ways to say factor VIII deficiency here in the SNOMED terminology. And each one carries some metadata that talks about the severity of the disease, whether there are immunologic complications to the disease, and so on. Right? These are important pieces of metadata in order to predict clinical severity, in order to predict the kinds of treatment a patient is going to need. And so when you think about studying hereditary factor VIII deficiency, you need to first recognize that it may come in a variety of different terms, and then recognize how these different terms may modify the way that you want to design your study. Conversely, we can often use these terminologies to our advantage. Right? So one of the common therapies for hemophilia is recombinant antihemophilic factor or recombinant factor VIII. You can see here that there are a number of terms represented in the RX norm terminology, which covers medications that can be prescribed and given in the United States. Right? Over on the right, what you're seeing are terms that deal with actual pharmaceutical products. So branded drug components, branded drugs, branded drug packs. These are the things that patients use or that clinicians use to treat patients. On the other hand, there are a lot of them, and it is often not helpful to have to keep track of all of them when you're trying to design a study. And this is actually a fairly minor use case, where we're talking only about 10 or 20 terms to keep track of. If you ask about, for instance, the common antibiotic used to treat things like ear infections or strep throat, you get into hundreds of terms in order to describe the variety of formulations and concentrations and brand names, when really what you want to know is, did the patient get amoxicillin? Right? So one of the things that RxNorm offers you is the ability to use the terminology to your advantage. Right? So here, for instance, you can start with recombinant antihemophilic factor if that's what you want to study. But really, if you want to study treatments for hemophilia A, what you want to look at is hemophilic factor, and the term antihemophilic factor, the terminology will make that connection for you. It then continues to roll it up through different drug classes or different drug functions. Here's an axis that is looking at biologic function. Right? So in these circumstances, what you want to do is use the terminology to your advantage, right? Use things like the ontologic relationship, the parent-child relationships in the terminology, to be able to say, what I want to study is recombinant factor VIII, and let the terminology get me to all of these brands, as opposed to needing to remember them every time I need to issue a query or do an analysis. All right, the corollary of terminologies, what's the structure of the data look like? So in PedsNet, the way we represent things is that each healthcare delivery system starts out with its own electronic healthcare record, and it starts out with its own internal data systems. And what we do as a network is that each of us extract information from those institution-specific systems. We transform them using a common set of specifications into what we call a common data model. You'll hear a lot more about this later in the training series from one of my colleagues, Hanya Rizaki. But suffice it to say that what a common data model does is tries to make sure that when we are looking at the same fact from different places, we represent it in the same way. We put it in the same place, we give it the same label, we use the same name for it. There are a variety of common data models, right? PedsNet is based on one widely used one called the Observational Medical Outcomes Partnership, or OMOP, common data model. But we also participate, for instance, in the PCORNet national network, which uses a different common data model. And part of what we do in the Data Coordinating Center is transform information back and forth between these data models in order to support a variety of different analytics. All right, so now you have data in your common data model and you're trying to design your study. What are the things that you want to think about as properties of the data? Certainly, when you're looking at data for secondary use, one of the key facts about your study is that what you have available to you is the data that are there. So unlike bespoke research, you don't have the ability to force the data into the shape you want it to. You can't require the patient to come and be seen at exactly 30-day intervals. You can't insist that the clinician fill out exactly your case report form. And there's actually some value to that, because if you want the results of your research to alter the delivery of healthcare, then you need to think about how that healthcare is delivered and adapt to it. So for classes of research that are not interested in ideal cases, or that are not interested in isolated biology, there may actually be advantages to this secondary use approach. But you do need to remember that the data collection is then driven by operational considerations, and things that impact healthcare operations more strongly or more discreetly may produce more complete data. You need to remember that it takes some time to get data from hospital information systems into that shared format and into the network's data repository. And so when you're designing studies, you need to take that latency into account. And you need to remember that business processes affect the appearance of data. So not only do they affect where data may be collected, but whether or not you need a particular diagnosis code in order to schedule a service or bill for a service is going to affect not only whether you collect that, but what diagnosis code you use, because those business processes have their own sets of rules about what things are and aren't acceptable. So you need to account for those in your study designs. You also need to account for the use of EHRs in the way you think about research. And what I would encourage is that you think of research as a collaboration between you, the person doing the analyses, and the person who's actually using the EHR. In that process, you need to remember that the person at the point of care is trying to do multiple jobs. At the same time, they are trying to take care of the patient. They are trying to make sure that the healthcare institution continues to operate and that the resources that are necessary to deliver patient care are available. And they're trying to do your research for you, right? So you need to take those roles into account in what you ask them to do. You also need to remember that what they do affects patient health and reflects the way patients present to the institution and the state of health of patients. And so what we want to do as secondary use researchers is engage with that and understand how patients experience their health and how the way we deliver care changes that. As a result, the most effective EHR-based research works with the workflows that are present in the healthcare institution and collects data from those workflows. It designs the analysis to account for not just the ways the EHR is used, but the ways the EHR could be used to change patient care. And it engages users at the point of care and at the point of institutional business planning in the process of knowledge discovery and the process of knowledge dissemination and change management. So what does that look like practically? When you're collecting data, one of the things that you want to think about is there a way to collect your data in a way that aligns well with clinical processes? So what I'm showing you here is a form that was deployed in the electronic health record by a large multi-institution collaborative for the care of children with inflammatory bowel disease called Improve Care Now, which collects data about patients who have inflammatory bowel disease that was not traditionally present in a way that was easy to capture in electronic health records. What was there was a lot of this information in clinician notes where it was very hard to reach. So what Improve Care Now did was shifted the shape of this data collection so that what the clinician is doing is clicking some buttons in a form rather than writing them out in the note. And then it's possible to collect that data once for the delivery of clinical care and for use in population health and health promotion and for use in clinical research. Now, it's important to do that in a way that aligns well with what the clinician is doing. So this form has to be easy enough to fill out, and there has to be enough reward for the clinician, right? In this case, this replaces the writing of notes and the calculation of disease severity indices. So for clicking these buttons, the clinician doesn't have to do a bunch of other work. Right? Similarly, what you can do is add some incentive for the physicians to, or the clinicians of any type, to collect the information that is going to help you. So here, for instance, is part of a clinical application that interacts with clinicians when a patient has ear infection to try to manage the use of antibiotics. So what it asks the clinician to do is fill out some check boxes that tell you how sick the patient feels, right? Does the ear hurt? Is there drainage from the ear? Does the patient have a fever? Those are the things we need to know, and what the ear looks like. And once we have that information, that's generally sufficient to decide what the diagnosis is and what level of antibiotic information is required, or what level of long-term follow-up. So part of what the system does is, in return for those checked boxes, it will present back to the clinician a plan of care that affects the visit today, and reduce the amount of work that the clinician has to do to saying, yep, I'm okay with that, or no, I'd like to change it, and here's why. Similarly, with this kind of discrete data, what the system can do is provide more information, right? One of the issues that clinicians face all the time in trying to treat ear infections is whether this is an isolated event or whether this is a recurring event that hasn't resolved, or is in a patient who is prone to repeated ear infections, and therefore may be at some risk for hearing or speech development, right? So part of what the system can do is save the clinician a whole lot of paging through prior visits and prior diagnoses by summarizing a lot of that data. What you can see here is when the patient has had ear infections, what kind of antibiotics the patient has received and when, and what other sorts of testing or referrals have been made, so that at a glance, the clinician can place this episode in the context of the patient's overall health. You can even move on from there and say, okay, we gave you some information to simplify early on taking care of this ear infection, but here's all the things that you might want to do targeted to treatment of ear infections in the patient. Let me make it really easy for you to get to the information you want. So you want to think about this way of interacting with the person at the point of care, so that their participation in research also helps them do their job and also improves the health of the patient. Secondly, part of engaging those workflows is asking, how do the things I need to know in my study, the analytic constructs, actually show up in the EHR? Right? So I mentioned, for instance, there is no patient who walks into the clinic and says, here's my slip with the D66 diagnosis code on it, right? So in some senses, it's a misnomer to say, if I want to find patients who have hemophilia A, what I should do is look just for that diagnosis code, because if it's there, they've got it, and if it's not, they don't. What you find is in the EHR, often it's there in patients who don't have the condition, because it's marking the fact that we thought about it, even if it wasn't there. Or often it's not there in patients who do have a condition, because the diagnosis is not sufficiently clear, it's masked by something else, or it just didn't bubble up in the list of things that we needed to record for business processes. But what you want to remember is that EHR data, unlike, for instance, administrative data, provides you with a variety of points of view, right? And so what you can do is take advantage of some of the various types of data that are represented. So there's clinician judgment in the form of diagnoses and referrals, but there is also direct measurement. So things like heights and weights, vital signs, laboratory data, and there are direct healthcare services. So you can capture the specialties in which a patient was seen, or you can capture the kinds of procedures that were done to help care for the patient. We should use that in our research, and that's a process that informaticians call computable phenotyping. What is the way to integrate the data, to find, if you will, the digital footprint of our analytic construct, so that we can recognize it using all of the information that's available to us. One of the corollaries is that depends not just on understanding clinical processes, but it depends heavily, critically even, on understanding where the data come from and what the quality of the data available to us are. So that means that data quality assessment, and in particular, assessing the way that data fit into the analytic needs of the study, are a key part of doing secondary use research. Again, we'll have another talk on that later in this training series. What I do want to point out is that it's often very useful to ask, what kind of primary data do you have? Here's a simple example from PedsNet. So we were looking at ways to study obesity, and one of the things that we did was we looked at how often we were measuring things like height and weight for a patient. And you can see that for any month of age up to about 16 and a half years of age, in PedsNet, we have well over 5,000 measurements of height and weight. So if we want to study the characteristics of height, weight, and body mass index, then we're in a great place to do that. If we want to study what that looks like in an individual patient, it's likely to be something that we have measured recently. So we can use those data at the population level so that we can do things like estimate the way the population behaves. If you've been in a clinical setting taking care of kids, you will recognize that we use growth charts all the time to compare the patient in front of us with what would be expected of other similar children. Right? So what you see here in the green line is the NHANES growth curve for body mass index in girls in this case, and the data that it were derived from. And you can see the shape of the curve here. You see a fair amount of hysteresis as kids get older, reflecting the fact that adolescent development happens at different times in different individuals. And when you have small sample sets, your point estimates will vary a lot. On the other hand, PedsNet is working with thousands of measurements per month of age. And so what you see is you get a very similar curve, but the effect of that hysteresis is really blunted as the measurements snap down to the curve month by month, because the scale of the EHR data reduces the variation and averages out over the population. It also gives you an excellent way to estimate how a particular patient compares to other patients and whether body mass index is elevated for a patient, which is one of the proxy markers we often use for obesity. Right? So with this direct measurement, you can estimate for most patients whether they're at a body mass index that we think puts them at risk for some of the health consequences of obesity. By contrast, if you look at diagnosis codes, you will find that except for weight management clinics, if you look at patients whom we know from body mass index meet criteria for obesity, there is no care setting in which more than a third of those patients actually receive an obesity diagnosis. And that happens for a variety of reasons, ranging from impact on utilization to the social stigma of describing a patient as obese and clinical practices which try to avoid assigning that label. But what it does mean is if you do diagnosis-driven research and you look for these diagnosis codes, out of the gate, depending on your data source, you are going to misclassify between 2/3 and 3/4 of your patients. Not a great place to start your modeling. You can also look at the longitudinality of data and ask how that affects your computable phenotyping. So here we're back in the IBD context. And what we're looking at are diagnoses of inflammatory bowel disease, so D, and use of medications to treat IBD. And as we go to the right along this x-axis, we're asking for more and more instances over time of data supporting the hypothesis that a patient has Crohn's disease. You can see that if all we ask for is one diagnosis, we will ascertain almost all of the patients who will have or go on to have Crohn's disease, but our specificity is fairly low, right? About a quarter, a little more than a quarter of the patients we describe as having Crohn's disease don't in fact have the condition. As we require more and more data over time, we get better and better at specificity, at identifying patients who actually have the disease, at a trade-off of losing some of our sensitivity. Now, that sensitivity loss is often in patients who are very early in their disease course or in the process of a diagnostic evaluation. And so you may judge that in your analytic use case, if you want, for instance, to do a retrospective study using longitudinal data, those are individuals who will contribute less data to a study, and therefore you may want to err on the side of greater specificity. On the other hand, if your goal is identifying patients for early therapeutics or for approach to participate in a registry, you may want to err on the side of sensitivity. So how you tune your computable phenotype depends on your analytic use case. Similar considerations impact your study design. And here, I think you want to remember two major considerations. Why are you doing the study, right? What is the result you want? What do you need to drive with that result? And therefore, how does the way you arrive at that result need to align with the delivery of healthcare? You need to be careful about trying to do things that give you perhaps an incremental gain in the statistical purity of your analysis, or in the link to particular disease biology, but in turn take away your ability to actually deflect care processes. You also want to remember scale here. Right? You want to say, again, if we have something that we measured directly thousands of times, maybe that's the way to build our hypotheses rather than looking at less common events. Finally, you want to ask what's going on in the EHR. So here, for instance, is a simplified conceptual description of a variety of patients who are seen for care of their inflammatory bowel disease over time. Right? So the x-axis here represents intervals in which a patient is followed based on clinically necessary visits. Some of those patients, labeled with a B, are treated with biologic agents. Some of those patients are not. They're treated with other agents, or they don't require disease-specific therapy. So there are a bunch of very pragmatic exposures to drugs and outcomes related to these drugs going on over time in these patients. And part of what we can do is rearrange that scattered process into a series of simulated trials in which we normalize time to each patient's drug exposure and then measure their follow-up over, in this instance, a 6-month interval. We need to be careful about the fact that we are not telling patients exactly when to come back. And so the interval of follow-up is going to vary a little bit from patient to patient, that we may see the patient at, instead of day 180, day 160 or day 190. And so we need to actually look at that ragged right edge, right? And there are a number of ways that you can do that that make it possible to rigorously analyze the data. When you do, what you can get to is a set of results that look remarkably like traditional clinical trials. So what you're seeing here is, in the darker red, the results of the REACH trial, looking at the addition of biologics to patients who are already taking antimetabolites to treat their Crohn's disease. And in lighter orange, the result of a simulation using secondary data from EHRs. And you can see that for both assessment of disease response and for assessment of clinical remission, so resolution of disease severity to a minimal level, the simulated trial produces results that are not statistically different from what the clinical trial did. The big difference here is that the clinical trial typically costs between $10,000 and $40,000 per patient, and often toward the higher end of that if you're following patients over time, and takes years to execute, whereas the simulated trial costs tens of dollars per patient and can be executed in a matter of weeks to months. Right? So this gives you the ability to do traditional kinds of analyses like Kaplan-Meier or Cox proportional hazard modeling. In this case, sort of predicting over time the likelihood of remission in patients treated with biologics in blue versus patients not treated with biologics in red, and derive estimates of treatment effectiveness. Now, I'm not saying that this should replace all clinical trials. This is subject to a different set of biases. I will be careful to say it's not subject to fewer or more biases than clinical trials are, but it is subject to a different set of biases, and there is a role for both. Right? Bespoke clinical trials do a better job in many cases than pragmatic trials, for instance, of isolating the biological effect of a compound. They do a less good job of detecting rare outcomes. They do a less good job of identifying barriers to effective use of treatment. So you need to balance the two, and each one needs its place in the overall spectrum of techniques that we use to better understand and better improve child health. So what I would recommend then is that we think about adopting the EHR as a tool in our research tool set. Right? It sits alongside bespoke trials, it sits alongside molecular science and other tools in order to give us a broader understanding of patient health. In particular, it helps us to balance pure or biologically informative science that helps us understand disease process and therapeutic process, but may be difficult to adopt in care, with pragmatic science, which tells us about the way that these health conditions or the way that these therapeutics behave in the real world. I also mentioned that it's important to reimagine the way we do research and the way we learn as a collaborative effort that reflects everybody along the spectrum of care, from the patient to the provider at the point of care, to the healthcare institution, to the researcher who is testing hypotheses. And finally, what I'd say is, particularly in the secondary use context, but really across the delivery of care, it's important to engage with the complexity of the data. Instead of trying to force the data into the structure that we want in order to simplify analyses, we need to be open to the story that the data are telling us, not to reducing our rigor, not to ignoring biases and confounding, but to understanding the ways that a variety of points of view on the concepts that we want to study help us to better understand them. And finally, what we need to remember is, no matter how we do this, because of the vast complexity of us as people, of healthcare deliveries, medicine is always going to be an uncertain science, right? So I'm giving this lecture in Philadelphia, one of whose adopted medical great-grandfathers or dead white males is William Osler, to whom is attributed the quotation, "Medicine is a science of uncertainty and an art of probability." We need to understand when we are getting conclusions that are as correct as we can make them, and not let perfection be the enemy of effective knowledge, right? But we don't want to get into a situation where we really don't know what happened, and we sort of look at the data in enough different ways, and we try enough different things, and then finally, poof, the result we want comes out of this complexity, even if we don't understand how we got there. All right, thank you very much for taking the time to listen to this talk. I look forward to talking to folks further.